We're back, 5:11 on a Thursday press box. Dan Rourke is here, Jim Rupert here, Chris Wottowa is visiting us, Dr. Chris Wottowa from Springfield Clinic Orthopedics. The Shed is brought to you by Springfield Clinic Orthopedics Walk-In, located at Springfield Clinic First 800 building, providing comprehensive evaluation and treatment of sport injuries, workplace accidents, and other acute injuries that require immediate attention. Walk in when you need us. Springfield Clinic, located at the 800 building, 800 North 1st Street. Dr. Wottowa, you specialize in arthroscopy, carpal tunnel syndrome, fractures, rotator cuff, shoulder dislocation, and wrist pain. You knew all that, I'm sure.
I did.
Okay.
I appreciate it, though.
Okay.
It's good to have it read to me.
Pull that a little closer to you.
Certainly. How's that? A little better?
That's great.
No, I do anything in the upper extremity that's bone and joint related, tendon problems and things like that.
How long have you been at it, Doc?
29 years out of medical school, and then 24 years practicing in Springfield as of next month.
What brought you here?
I'm from Belleville, Illinois, and so not too far away. And then I did my residency here in the early 90s, and then I did my fellowship away in New York. And then my wife is an attorney, and she is a public interest attorney, as they say. So she was looking for a job where there's a state capital, and I happen to have lived in a state capital, and so we came back here and been continuous at the Springfield Clinic since.
So you're a doctor, your wife's a lawyer, and your daughter picked journalism.
That's right.
What's wrong with her?
She was inspired by you.
She was inspired by me? Okay.
Yeah, she's been writing for the SJR for probably about 4 or 5 years now. She's a sophomore at an American University in D.C. She'll be leaving on Monday, so we'll be shuttling her out of here, and then we're going to help her move in a couple days later to her new dorm room. She started off writing for SGR, I think, in her freshman year, and then she was the head intern and chief here. And then this summer she did some freelance work.
Great training ground. It really is.
She loves to write. She loves to write, and it for me to write 3 sentences, it would take about a week, and you couldn't read it. And then she can sit down and fire it off in a heartbeat. So you play to your strengths, right?
But she's taking a vow of poverty, obviously.
Exactly.
By being a journalist.
One of my friends said she'll have a poet's salary.
If she's lucky. If she's lucky. Tell us, getting professional, what is carpal tunnel syndrome?
Carpal tunnel syndrome is compression of a nerve in the wrist. So if you look at the palm of your hand, and if you have 5 fingers on your hand, the thumb, index, long, and ring finger are the first 4 from the thumb over. Those nerves get their feeling from the median nerve. And then the meat of your thumb, the muscle there, comes from the motor branches come from that same nerve. So if that nerve gets compressed, you lose the feeling to the thumb, index, long, and part of your ring finger, and you may lose some muscle to your thumb. It's pretty common. I probably see 20 people a week with some version of carpal tunnel, early, late, afterwards. And everybody thinks it comes from keyboarding and things like that. There's been a gazillion studies looking at causation, and keyboarding really hasn't been something that's been felt to be a causative factor, but we all think it is. It's just no proof to it. So the numbers are high, and living in Springfield, which has a lot of white-collar clerical type jobs, a lot of people I see that have this. But I have people who are plumbers who get it, and doctors get it, journalists get it. All kinds of people get it.
What signs and symptoms? How do I know that the difference between I slept wrong, I had my wrist curled up under when I slept, or I have carpal tunnel? How do I know? What are the symptoms?
Did you have that? Can we do surgery?
Sure, right now. Start cutting.
Let's get to work. Typically, the symptoms are drawn out. You may wake up with your arm asleep 1 or 2 nights, but carpal tunnel will be repetitive. It'll bother you multiple nights. You'll wake up and shake your hand. The hand's numb. Things during the day, like driving the car, you'll have to move your hand around the steering wheel. Talking on the telephone, you have to switch hands. And they'll just say, I'm shaking my hand all the time. And sometimes I don't have to say anything. I just sit down in the chair, and the person just basically reads the textbook to me, because the symptoms can be really classic. And they don't get charged as much because they don't have to think. They give you all the answers, and then you can go from there. And it's easy to treat. You can just have them wear a splint at night, and we do all kinds of things to work on ergonomics in the office and talk about what they do day to day. And then if things get really bad, either we fix it, which is a relatively easy fix surgically, or we do some testing just to make sure, and then decide what to do, and go from there. It's usually not a big problem. It's a big problem when you have it. It's easily taken care of, and it's easy once you get it taken care of and done with it.
What's the surgery like, and what's the recovery period if you have the surgery?
Depends on what you do for a living. If you're a pipe fitter, you're going to be off work probably about 4 or 6 weeks. Run a jackhammer, it's 4 or 6 weeks. If you're a bank president, you go back to work the next day. Just sit in your office and tell people what to do. It's an outpatient procedure. We do it mostly under a local anesthetic. I try to get it down to like a dental procedure. Like you go to the dentist and your tooth drilled and you go back to your life. So that's the goal. That's the goal. And then some people have a little discomfort over the hand, and they have to modify their activities. But other than the risk of infection, it's a pretty straightforward procedure. 26
years ago, when you're starting out in this, did we have carpal tunnel syndrome in those days? You guys keep finding stuff. You keep finding rotator cuffs and all kinds of things that have wrong with us.
I would say that the problems I'm treating today, 29 years later since I got out of medical school, they're the same problems. The techniques might be a little different. I did carpal tunnel surgery with Dan Adair in 1990, my hero and role model in life. And he's since passed away, as most people know. And in 1990, we would admit you to the hospital the night before your surgery. You would spend the night, you'd have your surgery the second day, and then you'd go home the third day. Now I have got a drive-through window at the office. You pull up, you stick your hand in the window, I get a rusty grapefruit spoon and whack it a little bit, and then you go back to work the next. It's not quite that bad, but it's the same disease, it's the same process of diagnosis, but the treatment is a lot different. And that's where medicine, I think, in general has just gotten to be so wonderful, is that our technology is allowing us to do the same things we did 20 years ago, 30 years ago, better, less invasion, less downtime. Not to ramble, but rotator cuff surgery used to be 9 months off work for a lot of people. We can do that arthroscopically. That's happened in my lifetime, and the recovery time is less than half. It's incredible.
Is rotator cuff surgery still require sleeping for weeks in a recliner and all that kind of stuff? That's the negative stuff that I hear about rotator cuff, because I got a bad shoulder.
Yeah, you do. You don't have to sleep in a recliner. A lot of people do. I always say sleep where you can sleep. If you can sleep in a bed after the surgery, you can sleep in a bed. Most people, it takes a few weeks to even a month or two before they get back to sleeping in the bed, especially if it's a big rotator cuff surgery. There's a lot of downtime with that. But compared to what we did before, where we would open the whole thing up and take muscle down and things like that, the recovery was brutal, and it's not anymore.
And the fact of the matter is, you guys will really go to great lengths to not do surgery, won't you?
Oh, that's probably the biggest thing I think almost everybody in town really focuses on. This is a really good medical community. Not just me.
Really good.
It's really good. The people are, conservative is not the appropriate term. They're appropriate. They do the proper thing. There are so many things you can do for patients that don't involve surgery. It takes a little extra time. Actually, as I get older, I kind of like that. If I see somebody in the office and can get them better without doing something, invasive that takes a long time to recover, I get as much of the joy doing that as I do, doing a routine surgery.
How many, sports-wise, because sports are very big for you. You've got a son that's an athlete. My son was a patient of yours when he was sent to St. Louis to have Tommy John surgery. How much more are you seeing it in kids? In 2004, when my son messed up his elbow, the first thing he said was, "I hope I don't need Tommy John." I'm like, "You're too young for that." How young do you see kids messing up their elbows bad enough to need Tommy John these days?
Can we go the full hour on this? Because I could probably do an hour. Let me try to distill it down to, I guess, sort of like where we are right now. 12 and 13-year-old boys get a version of Tommy John. They can actually, when they're growing, the ligament that is involved in the Tommy, for those who don't know, Tommy John is a failure of the ligament in the elbow on the inside, right next to your ulnar nerve, that fails from repetitive throwing. In young people, they're growing. and under the age of 16, the growth plate's open. So what we actually see in the kids under 16, it's really 12, 13, 14, and sometimes 15. The growth plate fails. They actually will contracture through the growth plate, or they have what we call an inflammation of that growth plate. So we're seeing it very young. And everybody says, oh, it's from the curveballs. It probably isn't from the curveballs. There's been a lot of studies looking at the curveball. I go to a meeting about every 3 years it's a great meeting. It's only upper extremity. It's only throwers, and we have it in New York at the MLB headquarters. So we're in Joe Torre is the guest speaker. They have all the uniforms of the players there. It's a great thing. And all the gurus get together. And last time I was there, I'm going in November. I just booked the trip with my staff this week. But last time I was there, the big push was the fastball. Its velocity is what equals Tommy John injury. So if you look at somebody's velocity as they throw, 93, 94, 95, 96, plot that on the graph, and it's a straight line going up. As you go up a 1 mile per hour at that elite level, that's where your ligament fails. So it's probably repetitive pitches, it's probably full exertional pitches, and throwing hard. And even if you throw low 70s, but you're throwing as hard as you can, that's going to be the exertional pitch. At the elite level, it's almost a 1-to-1 ratio. Each mile an hour increase, you'll see an increase in chance of injury. So when Ohtani last year was having problems, and I was watching MLB like everybody else, like, well, we're going to shut him down for a little bit. I'm like, shut him down? He throws 96. His ulnar collateral ligament is done. And then sure enough, he hit for a little bit, and he had it done, and he's hitting now. But that's the way it goes. The one new thing in Tommy John surgery that is really interesting is what we call the Manus procedure. Seth Manus was a pitcher for the Cardinals probably about 2 years ago. If you have an acute injury, like within a couple weeks, or if you have a partial injury, we can now, and I haven't done this procedure, I sent him to George Paletta because he's awesome. We can do an internal brace where they actually put an anchor above and below, and they can repair the ligament, and they have almost like a piece of tissue that's like a belt, a very miniature belt that's basically adhere to the bone, and then that acts as the ligament while the old ligament heals.
Done with a scope?
No, it's done open. We do UIS as well, so I got a couple pitchers who have gone down there, and so I do their rehab up here, and the incision is about the size of a quarter.
Wow.
You can put a $50 over the incision and hide it. So
and you don't have, because my son, the taking out the ligament from the wrist, that was almost more painful later on than the other part.
Did he have it from the same side or the opposite
Opposite.
side? Yeah, he's been doing it from the opposite side for a while. I took it, when I do it, I take it from the same side. It does bother them. You don't need to take a donor graft like that for this procedure. It's a limited person. It's a limited window of indication. It has to be somebody who, A, is a throwing athlete, B, has a relatively acute injury, and C, either has partial tearing or evidence of high-grade acuity. If it's a chronic tear, most of these things, they just wear out. It's like your jeans are too long and you're stepping on them and they start to fray. That's usually what happens. Those people have to have the full thing reconstructed.
Final question for you, final comment from you. What made Dan Adair so special? He's touched so many people in this community.
Okay. I would say it was how he would sit down in front of a patient and engage with that patient. So he sat down, looked them in the eye, found something to talk to them about that may or may not be related to their problem, made that connection, and treated that person with such respect. That is something that, today I think about him every day because I try to do that with my patients. Half the time I'm clicking on my stupid computer, and I apologize. I want to look at you in the eye, but I have to click over here for a few minutes, and I do that. But he would sit down and engage patients, and he was an excellent surgeon. He did a great job. He was never in a rush. One quick story. I told this story to his kids at his memorial. I was doing a total knee with him when I was a resident, and we're getting ready to do it, and He says, hey, we're getting our hands scrubbed. And he goes, hey, Wottowa, I got an idea, Wottowa. Why don't we make this the best total knee we've ever done? Sounds like a good idea, Dr. Adair. So we did the total knee, and the whole time he's like, this is going to be pretty good. This is going to be pretty good. This is an operation he does like 6 times a day. We finished, and he's asking, is that the best total knee we've done? Is that the best total knee Yeah, Dan, Dr. Adair, that's the best total knee we've ever done. So we walk out, and he goes, well, we got another one to do. Let's do this one better. I mean, that attention to detail, that sort of commitment to the craft, I mean, that's what made him special.
Thank you for visiting with us today. We'll see you on the sidelines at high school football games because they need you, but you like it too.
I like it. I'll be in the booth with you when it's raining.
Okay.
If you don't mind.
We'll find a spot for you.
Perfect.
All right. Dr. Chris Wottowa from the Springfield Clinic Orthopedics, the walk-in clinic. We're going to take a break and be back for more on Sports Radio 1450, 92.3 FM.